Disc herniation, particularly in the lumbar spine, is a common musculoskeletal condition that affects a significant portion of the population in North America. The prevalence of disc herniation varies depending on factors such as age, gender, occupation, and lifestyle. Up to 35% of people will experience symptoms related to disc herniation at some point in their lives. Disc herniation is most common in individuals aged 30 to 50 years, with a peak incidence in the 40s. Lumbar disc herniation is the most common type of disc herniation, accounting for approximately 90% of all disc herniations. Approximately 1 to 3% of the population will experience symptomatic lumbar disc herniation at some point in their lives. Cervical disc herniation is less common than lumbar disc herniation, but still affects a significant number of individuals. The prevalence of cervical disc herniation is estimated to be around 1% to 2% of the population annually. Certain occupations that involve heavy lifting, repetitive bending, or prolonged sitting increase the risk of disc herniation. Occupations such as construction, nursing, and truck driving have been associated with higher rates of disc herniation due to the physical demands and postural stress involved. Obesity is also a contributing factor, as excess weight places additional stress on the lumbar spine, increasing the likelihood of disc degeneration and herniation. In the US, it is estimated that $50 billion is spent annually on the treatment of lower back pain, much of which is related to disc herniation. In central disc herniation, the herniated material pushes directly backward into the central spinal canal, can compress the spinal cord or cauda equina, leading to symptoms like lower back pain, bilateral leg pain, and possible neurological deficits like weakness, numbness, or bowel bladder dysfunction. Posterolateral disc herniation is the most common type of herniation. The herniated material pushes backward and to one side, often compressing the nerve root. Symptoms include unilateral lower back pain, radiating pain along a specific dermatome, and possible muscle weakness. In foraminal disc herniation, the herniated material extends into the intervertebral foramen. In extraforaminal disc herniation, the herniated material extends beyond the intervertebral foramen, compressing the nerve root outside the spinal canal. Symptoms are similar to foraminal herniation, but may be more severe due to direct nerve root compression. In disc bulge, the annulus fibrosus, which is the outer layer of the disc, remains intact, but the disc extends beyond its normal boundaries, causing a generalized bulge. The nucleus pulposus, which is the inner gel-like material, is still contained within the annulus, but the disc is compressed and flattened. Symptoms of disc bulge include 1. Mild to moderate pain. 2. No significant radicular symptoms unless the bulge compresses a nerve root. In disc protrusion, the nucleus pulposus pushes against the annulus fibrosus, causing a focal protrusion but without complete rupture of the annulus. The herniated material is still contained by the outer layers of the annulus, but it may compress nearby nerve roots. In disc extrusion, the nucleus pulposus breaks through the annulus fibrosus but remains connected to the disc. The herniated material extends into the spinal canal or intervertebral foramen, often compressing nerve roots or the spinal cord. Symptoms include severe pain, significant radicular pain, muscle weakness, and possible neurological deficits like reduced reflexes and sensory loss. Disc sequestration, which is the most severe stage, where a fragment of the nucleus pulposus breaks off and becomes a free fragment within the spinal canal. The sequestered fragment can migrate and compress nerve roots or the spinal cord, causing severe symptoms. Acute trauma can lead to a herniated disc. Additionally, Improper lifting of heavy objects places excessive pressure on the spine, which can result in a herniation. Professional athletes, particularly those involved in contact sports, are at a higher risk due to the physical demands of their activities, which can involve sudden impacts and torsional movements of the lower back. Lifestyle choices, including obesity and physical inactivity, significantly contribute to the risk of disc herniation. Excess weight adds strain to the spine, while a lack of regular exercise can weaken the muscles that support the back, increasing susceptibility to injuries. Furthermore, poor posture during daily activities can exacerbate stress on the discs and lead to herniation over time. As individuals age, the spinal discs undergo a natural process of degeneration. This involves a loss of water content, which decreases the disc's flexibility and makes them more susceptible to tearing or rupturing even with minor strains or twists. Genetic factors can also play a role in the likelihood of experiencing a herniated disc. Individuals with a family history of spine problems may be more predisposed to this condition. The hereditary aspects may influence the integrity and resilience of spinal structures. Repetitive motions or prolonged stress on the spine can lead to wear and tear of the discs, making them more prone to herniation. This may occur in various occupations that require heavy lifting or repetitive bending. The goals of physiotherapy protocol for disc bulge are 1. Reduce pain and muscle spasm. 2. Prevent progression to more severe stages. 3. Improve lumbar mobility and core stability. Manual therapy is used for 1. Soft tissue mobilization to reduce muscle tension. 2. Gentle lumbar mobilizations to improve joint mobility. Exercises include 1. Stretching for hamstrings, hip flexors, and lumbar paraspinals. 2. Core strengthening using pelvic tilts, dead bug exercises, and bird dog exercises. 3. Aerobic conditioning, low impact activities like walking or swimming. Instruct patient proper lifting techniques and posture, and encourage regular movement breaks for sedentary individuals. Electrotherapy modalities as well as heat or cold must be used as well. Goals of physiotherapy protocol for disc protrusion are 1. Reduce pain and inflammation. 2. Improve lumbar and nerve root mobility. 3. Strengthen weak muscles. Manual therapy is used for 1. Joint mobilizations to improve mobility. 2. Neural mobilization techniques like sciatic nerve glides to reduce nerve irritation. Exercises include 1. Mackenzie extension exercises, prone press-ups to centralize pain. 2. Core strengthening, planks, bridges, and side planks. 3. Strengthening quadriceps, glutes, and hamstrings. 4. Aerobic conditioning, stationary biking or elliptical training. Electrotherapy modalities as well as heat or cold must be used as well. Goals of physiotherapy protocol for disc extrusion are 1. Reduce severe pain and neurological symptoms. 2. Restore lumbar and nerve root function. 3. Prevent further disc damage. Manual therapy is used for 1. Gentle mobilizations to reduce stiffness. 2. Neural mobilization techniques for radiculopathy. Exercises include 1. Mackenzie extension. Exercises including prone press-ups to centralize pain. 2. Core strengthening including planks, bridges, and side planks. 3. Strengthening quadriceps, glutes, and hamstrings. 4. Neuromuscular re-education including balance and proprioception exercises. Electrotherapy modalities as well as heat or cold must be used as well. Goals of physiotherapy protocol for disc sequestration are 1. Manage severe pain and neurological deficits. 2. Restore function and prevent complications. 3. Prepare for surgical intervention if conservative treatment fails. Manual therapy is used for 1. Gentle mobilizations to reduce stiffness. 2. Neural mobilization techniques for radiculopathy. Exercises include 1. Mackenzie extension exercises including prone press-ups to centralize pain. 2. Gentle stretching. 3. Core strengthening including isometric exercises like pelvic tilts, gentle bridges. 4. Neuromuscular re-education including balance and proprioception exercises. Electrotherapy modalities as well as heat or cold must be used as well.